We got cut off there. So ending it was the make sure you empty your trash when you're doing videos and stuff on your phone, because it still takes up storage apparently. Just saying about how profound the relationship was growing up with my pediatrician. That's where my mind was going, and I think that's the thing that really we don't talk enough about. And there's this, again, misconception, this myth that PCBH isn't about relationships.
Yeah, and we did talk about this in the one PCBH Corner a while back, that a lot of it is a function of it being a newer field. You know, really, it's
well said.
Yeah, it's
well
only
said.
been the last couple of decades, and we know it takes a while. And so you and I have been in the same clinic now for 9 years, and so when we were learning about PCBH and a lot of the mentors that we had like in the clinic, sometimes they'd only been there a few years because, again, it was so new, and you keep trying to hire. So sometimes they didn't have the experience of seeing somebody. What would it be like to have a relationship with a family or multiple people for 5 years? And now we're at 9 years. And I know we've talked about this before, and it's probably because we can't stop talking about it, that is like a hidden gem of PCBH. It's just the relationships and the continuity and that longitudinal episodic relationships. And it's so, like you said, it's so profound.
What you just said there, and I think we have talked about this before, but the way you described that right there, really just about the field, and then what we're talking about, so if your field is only like 30 years old.
And that's generous.
Generous, right, for PCBH. There hasn't been enough time yet for us to even talk about the continuity and the relationship within PCBH, because it's too young for that to be discussed right now, you know? So that is really, really interesting, because we probably haven't had too many people, probably now they're actually starting to have this, we haven't had too many people stay in systems and within PCBH to be able to talk about it for 10, 15, 20 years.
Yeah, whereas like when our family medicine residents are coming through, they have how many physicians who've been family physicians for 3-4 decades in some cases.
Bridge, that is really, really profound. We need to start probably writing about that a lot more now, right? Because we know that now. We didn't know that back then. Now we know that now.
I mean, I know I've made snippets on this about like, you're not going to probably be a very good BHC for about 3 years is what I kind of say, which, you know, is kind of arbitrary. But I think it points to just the amount of upskilling that it takes and the steep learning curve that it takes to become proficient as a BHC. I don't know where I was going with that.
Well, we were talking about again, we haven't had enough time for people to learn about
Yeah, I always tell our trainees and folks, I'm like, listen, the hardest year that you're ever going to do in PCBH is year number 1.
Year number 1.
Because every single person you meet is brand new, or at least for a big chunk of the year. It's kind of neat. By the end of the year, you start getting that. And so it's all the hard parts of PCBH. And especially if you're doing a practicum rotation, okay, I did 3 months. But like a lot of the rewards and what is that makes your just heart just beat for this work comes at year 3, 4, 7, 8, 9.
Literally, this is, again, just well said, because my mind's just going so many different places about this. I'm even thinking about the reinforcement that I get as I walk through the clinic, and there's so many patients that I've seen before, and I get to say hi to, and I'm not seeing them, today. They're doing okay or whatever. I just had this happen last week where a patient came in that I'd seen for a decent while, but I haven't seen in years and stuff. And they had come in, they were checking, and they were like, "Hi, Dr. Bauman," and stuff. In that moment of like, that was so reinforcing. Like that was that relationship, and you don't get that in year 1.
And you don't get it with a practicum rotation.
No, you definitely don't get it with a practicum rotation. And that's interesting.
Yeah, so I mean that heart, and whereas like in family medicine,
that's interesting.
It's talked about. So even though sometimes they're not experiencing it, although they do have a 3-year residency, I guess if you did like a sub-I or something, you wouldn't get the full experience of that continuity of that relationship. But it's talked about. It's in the milieu of the field.
Bridge, that is again.
And I mean, not to mention the entire previous PCBH Corner that we've been shooting, where we're not even highlighting, and within the field, we're even having arguments whether or not PCBH is even relationally based as a misconception. We're talking about 1 to 4 visits only. So if you're only doing 1 to 4 visits, even if it was episodic, you wouldn't be thinking about like, oh wow, what's really cool about PCBH is that I'm working with families like long term over the course of their life. And so we've set this up where it's like, hey, do you want to work in a really sterile environment where you can do 20 to 30 minute visits, and guess what? You get 1 to 4. And if there's severe problems, we're definitely going to refer them out because it's going to be triage and refer. And you know what? Even if it's not severe problems, but you get to session number 4, or I don't use the word session, but visit number 4, then you're going to go ahead and refer them out. It's like, I don't know what that is, but don't sign me up for that.
And as you said, you can, when you take a step back, you can see why that language has developed.
Yeah, because I mean, it is descriptive,
and like what you were saying just now, though, is that no one has really had the experience of having the continuity of the relationship and how valuable that is. That is really profound. I got one more, and I would assume we'll probably wrap up.
It's a little bit longer one, but that's all right.
That's okay.
It's good. It's a big topic.
You said something a couple minutes ago that I was like, yep, that's a big myth. That's a big misconception. That this work, what would it be? That this work isn't deep work? That this work is, that it's simple?
Yeah.
That it's simple work. I was just talking about this with our BHC trainees, that, and we often talk about, like, you know, PCBHers, I feel, my mind says, you know, in the way that we train PCBH is like, we're like the surgeons that have to know so much information about human behavior, about evidence-based interventions, about a variety of different conditions that are coming in, and then to be able to work with someone in a moment to come up with a plan that is contextually influenced, sees the person for who they are, is going to prompt engagement based on evidence in something that's going to be pragmatic, all within an efficient amount of time. That is not simple. And I will say, and I'll say this with a little bit, I don't know, I'm interested, you might not like this, even me saying this, so let me know if you don't. I am much more intentionally going to be like standing on a soapbox talking about this, is like, we need to stop simplifying healthcare.
Yeah.
We need to stop trying to pull away the complexity of what these things are and what working with humans actually means. And I think that's a misconception and a myth about PCBH. Like you said, to make the joke, it's like you're gonna give everybody a deep breathing handout, or it's gonna be very algorithmic. It's gonna be a bunch of sleep hygiene. It's gonna be just these basic algorithms that you're going to apply that really anybody could do in the medical field if you just gave them enough training. Like, this is actually incorporating all of your skills as a behavioral health provider, from how you interact with a patient, from the idea of contextualism, for your vast knowledge base about, again, human behavior, as well as evidence-based protocols for a variety of different conditions, as I said, in a pragmatic, contextual way that keeps the patient engaged.
Yeah, it's like Michael Jordan said that, like, hey, just because I make it look easy doesn't mean that there's a ton of work. And if you're a proficient BHC, you'll make stuff look easy, but it doesn't mean that it's simple. And we had shadowers just recently that came and checked out the clinic, and it was cool. I guess I needed that reinforcement. I didn't realize I needed that reinforcement. But she said, I watched what you were doing, and it seems like maybe somebody could have thought it was like simple or just kind of like on the surface work. But she's like, I saw what you were doing. She's like, you were funneling and you were orchestrating. You were doing all of that in that visit to get to something that just felt so easy and felt like, well, of course, like there was no other option other than we were going to do what we were going to do. And so I have never, most of the time when like physicians shadow us, they're like, oh my gosh, Dr. Beachy, you're so nice. And that was like an easy visit.
Right.
And it's like, do you know what I had to do to make that look like an easy visit? But it was cool because we had some, you know, in this case, it was a mental health provider. So they
knew.
Yeah, they knew all the different points that it took. And I think that that is sometimes the case, that if you do the contextual interview and you do it well, your intervention and what you're going to do is like served up on a platter. And I know Jen, our good friend Jen Y and colleague Jen Y, she'll say that. She's like, you guys make it look easy, but it's only because of the amount of expertise that is going into it.
It's a skill set. And
it's such a strong skill set to make it look.
And we even had our trainees say this recently about shadowing the BHCs, and they're just like, everybody's just like a bunch of wizards, like in here, like moving visits along and incorporating. That's where, honestly, for me, it's like to use the highest level of someone's professional degree within behavioral health. I think it's within PCBH, and that's oftentimes not what is portrayed.
Well, you've always said you're a ninja. You have to be a ninja.
Correct. And so I think that is one of the final, I mean, there's a lot more, I'm sure, misconceptions and myths that we can go over. I just, we could go over the myth about like visits have to only be 30 minutes or, whatever those things. But I think those are the big ones that come up. And I think it's the big ones that also cause people, if they're believed, goes back to our last PCBH Corner about warm and fuzzies. It prevents warm and fuzzies from occurring. Like, it erodes people's want to do this work when those myths are uptaken.
Yeah, so I think, let's see if I can do a little summary. In summary, PCBH work is deep, it's meaningful, it's relational, it requires a ridiculous learning curve and skill set.
Ridiculous learning curve and skill set.
And it literally couldn't be further from the truth that this is about triage and refer, that this is about being a walking handout or giving a handout, and that it's about getting people to somewhere where somebody can actually help them. You can help them here and now. Even if they did go to a higher level of care in a situation.
Correct.
You're still going to help them the same way a physician or a PCP is somebody's PCP, whether or not they go and see an endocrinologist or a gastroenterologist or a surgeon. They're still their PCP and they're still helping them with a lot of things.
It got me hyped. And I think that was a great summary. I think that was an awesome summary. Let us know where your mind goes.
I know, we said some stuff today.
Yeah, and I think this is a good thing. I think we're getting to the point in the field where we can have more of these discussions and these robust conversations and really kind of dissect these different things. So reach out to us for sure. Send us an email. As always, thanks for stopping by.